one can depress the infections, but the outcome hasn't changed much. Look at this. In intensive care, there was a control group of 163 patients, and in the treated group, 161, and the treated group, 163. This is published in Lancet in 1988. They saw a significant reduction in the incidence of acquired infections, but no impressive reduction in mortality and no difference in stay in ICU. And there was a referendum, a consensus conference among intensive care doctors in France a few months ago, and they decided that this treatment shouldn't be given outside studies. It has not yet documented itself. This is my most important slide. You can forget about everything if you do not forget about this, because this explains then why selective contamination is not working. A young surgeon in Australia working with ulcerative colitis wanted to know the mechanisms of eventual development of ulcer in the among the colonocytes. And he did some basic studies on the nutrition of the colonocytes. He came to the conclusion that the colonocytes receives most of the energy supply from the colonic lumen. To make it clear, colonocytes cannot eat from the blood. They eat from the feces. But if there is if there are no nutrients in the feces, there will be no growth. They will atrophy. And this is the most important finding. And what we have been doing as surgeons and physicians in intensive care, we have starved our colonocytes to death. We have opened up the membranes. So what is happening, as a matter of fact, and I will go more into detail with that, we do keep our patients in intensive care. We give them prophylactic antibiotics for long periods of time of a type which destroys the normal flora. We do feed them parenterally, and that leads to an atrophy of the colonic mucosa. After a week or so, the mucosa is thin and cannot function anymore, and the bacterial flora is dominating pathogenic, and then the translocation starts. And this explains why the chances of outcome decreases with stay in intensive care. We thought for a long time that fiber-free diet was excellent, you know. They constructed the astronaut diet, you know, the defined diet, only amino acids. And it's good for the stomach. It's good for the small intestine, but there's nothing left for the colon. And today we know that fiber-free enteral diet induces atrophy in colon and distal small bowel, and that TPN, total parenteral nutrition, induces atrophy throughout the intestinal tract. But we know also that if we give fiber, and an excellent fiber is pectin, we can increase the colonic mucosal cell proliferation, and we can regenerate the colonocytes. And this has led to understanding that the old concept of bowel rest is very bad, you know, because the bowel rest deprives the colonocytes their fuel. And that we should look after that we and our patients receive fuel for our colonocytes every day. And this fuel cannot come out of simple carbohydrates or of amino acids. It is necessary with fiber, which is the type of food which is directed for the colon by our Creator. Because fiber cannot be absorbed in the stomach, cannot be absorbed in the small intestine. It can be digested by bacteria in the colon to produce nutrients for the colon, and this is what's happening.